Thank you. So I'm Gina Franco. I'm a nurse practitioner. I'm a breast cancer survivor, and I'm one of those people that works in the field for many, many years. I've worked in oncology since 1981. So triple threat. Uh, I'm going to talk about challenges. And some of this is different. If you notice, our slides aren't as pretty because we really wanted to address some of the issues that you asked us to address. So pardon us with just all the text only. We want to talk about the survivorship care plans, how we engage survivors, what metrics we're using or used, lessons learned, our wish list, our feelings or thoughts about sustainability, care coordination, as well as models of the future. So as Mark said, we're taking our data from our cancer registry, and we're also taking our referrals from the cancer registry. One of the problems with our EPIC system is that pathology is not into our EPIC system. So we have to put in our own diagnoses. So when we developed this whole process, we actually got the data from our cancer registry. And I know some cancer registries are about 3 to 5 months behind. Ours is not. I'm not sure why the difference is, but we actually are more of a timely cancer registry. So we get our referrals from there. We do a lot of cold calling because of that, but we also get our data. We get about a 50% crosswalk from that system into a embedded survivorship care plan, and then we have to populate the rest. It takes about 6 minutes per patient. But again, when you start getting into high numbers, that actually can mean a lot. So how did we engage our survivors? And so I'm going to jump to each of these kind of quickly because we don't have a lot of time. One of the things we did is develop our own survey because I don't know if you know, but HCAHPS and CGCAHPS, what most of the hospitals use, don't really engage services per se. They're more physician-directed. Well, we have more nurse practitioner-directed clinics. We have Dr. O'Rourke there in 2 afternoons a week, but primarily the rest are dietitians, social workers, and nurse practitioners. So we had to devise a satisfaction survey that was more service line so that we couldn't just say, were your appointments on time? Because we really wanted to know which appointments mattered. We also looked at this from an aggregate total as well, and we built in quarterly analysis, and then we actually look at all of this in our staff meetings. We review these results, and then we identify what changes are. And one of the biggest changes that happened for us a few years ago is we changed the timing of when we see these patients. So we see them at the beginning of their treatment, when their treatment begins, approximately 4 to 6 weeks after their treatment begins. COC really says we have to do it within a year, and most centers are doing it at the end. That's fine, but our feedback was that people wanted to know some of these things during the treatment. Caregivers wanted to know how to help during the treatment, so that we changed that, and we offer the option of coming in at the end, but they don't have to. That's just purely an option. And we mail the completed survivorship care plan at the end. And most of the time we're seeing, and I think Mary and others have talked about the risk analysis, most of the people opting to come back are the people that are having multimodality treatments, radiation, chemo, surgery, and they just can't get through all of that to look at more after all that treatment and talk about that. We also have our survivorship registry, and that has been really a game changer for us. So that's an IRB approved registry. It is a 5-page consent, the same as we use for drugs. And we actually ask our survivors to be part of a database. I tell them this is the no-spin zone. We're not going to sell this list. We're not going to try to sell you anything. But we will push out some periodic, and it's 2 to 3 times a month, whether there are focus groups, whether there are announcements for cancer survivorship, whether we want you to participate. We have a patient engagement studio. And that allows us to be in touch with our survivors because we may never see them again beyond that one-time experience. That's a downside of destination clinics, but this is in a way of allowing us. We've also done surveys on specific subgroups, patients that had breast cancer in the last 3 years at a certain area. Did they like where they had their breast biopsy? So we got feedback and actually could look at those results to make changes in our whole microenvironment. Evaluation tools and outcome measures. Well, we looked at the satisfaction surveys, as I said. We have had focus groups. We've had staff feedback, a lot of staff feedback. We look at where our referrals are coming from as well as our growth patterns. We look at monthly visits, we look at our no-shows and our reschedules. We have to call people sometimes twice to make sure they come in. We call them 4 days ahead. We don't use anything automated, although some of the data says it really doesn't matter whether you call them automated or a human person calling. But because we're a destination clinic, we have to make sure that people know where they're coming. Our compliance with COC, certainly an outcome, as well as our screening compliance, and what is our participation in group rates. You know, if we say we're having a weight loss group, we'll get about 5 to 10 people come in. If we put cancer fighting in front of it, we get 30. So it's amazing just the way you even title things. And the other thing is when you have cancer fighting in there, it also engages the caregivers because they feel they're part of that team and they can do something. So our lessons learned. Our lessons learned are many. One size doesn't fit all, that's certainly true. And each survivorship visit needs to be prepared and be patient-specific to the point of that you can make it, but then you really have to individualize that visit. So that really takes a skilled staff, and I can't under or overemphasize that enough. You need trained staff. The downside of doing this in embedded clinics is that you're asking acute care people to talk to people about things that they may not really talk about most of the time, whether they're sexual health questions, body image questions, whether they know where pelvic floor therapy is in your community. They may not know those things. I worked in acute care. I didn't know these things. I know many people that didn't either. So we really do need trained staff. There needs to be a high level of detail and specificity, and this can be time consuming, so that's definitely a challenge. We've really tried to economize on this by making our care plans not so pretty, and it's really about the process. We focus on lifestyles and habits, and that's really a challenge because if you build it, that doesn't always mean they'll come. There is a disconnect on what we do to our bodies. You know, I tell people that we'll go across town to get ethanol-free gas, but we forget what we put into our bodies day in and day out really matters. And I'm not trying to be casual about that, but it really is true. I mean, we're watching our society get unhealthier and unhealthier, and us being in the field, we can change it to a degree, but we really need a lot of public health policy as well as a lot of Dave E. patients if he's around. And the guidelines are confusing to follow, lastly. We have a lot of guidelines. I think people have talked about that already, about preventative care, about secondary cancers, about surveillance. It's confusing to us in the field, and it would be better to have these more streamlined. Psychosocial care, it's really tough. In our state, and in really our community, mental health care is our poorest sub-care that you can have. So it's really hard to get people that are underinsured or uninsured the care they need mentally. We're handling things in distress that are not really distress related per se. We get calls about living wills, we get calls about other family members, we get calls about everything, but there's really no one else to do it. And if you don't help those people, they're the people that aren't coming in for their appointments, or they're the walking worried. So those are the people that we need to take care of, but we don't always have the army of staff to take care of them. And the healthcare maintenance and screening is often neglected, as you all know. So I tell people we're like the quality assurance for you as well as for us. So you may say you don't want a colonoscopy or you can't do this right now because you've got 6 months of chemotherapy. Well, we're kind of saying, okay, well, maybe we can schedule that 8 months. You can always cancel that appointment. But sometimes when you have a second look, independent group saying, you know, that really does matter and you really should do that, and this is why, and give some reasons, we can get things done when they say to their initial oncology team, I don't want to do that. And primary care management is tough. I don't know if you've all noticed, but primary care people switch a lot more now. So these lifetime relationships we don't have anymore with our patients, or our survivors don't. So it's often hard. If there's not a great relationship to begin with, it's really hard to create one during a cancer experience. And it's really hard to convince people you need to go right back to that primary care person when you're done with your treatment, because they're pretty tired of coming to offices. So they don't necessarily understand that the care coordination has to happen both on our side as well as on the patient side. So we wish that the value of survivorship care plan visits were realized by everyone, both lay and medical. I mean, we struggle too in terms of trying to convince our acute care personnel, that we're not robbing staff from their infusion centers, that what we're doing really matters for that cancer care, that it's not just psychosocial care, it's psychosocial care, lifestyles, habits, the environment you live in, everything. It's holistic care. And that EHRs, and I don't see many EHR people here or that we've even talked about it that much, but we need them at the table because we are dying on the vine with trying to create these specialty products in each community and paying for it dearly. We need them to have it streamlined so that we don't have to try to recreate the wheel every time we all roll into this holistic EHR. And we need to have better guidelines and better ways to help communities. You know, we're a sophisticated community, but there are a lot of non-sophisticated communities, and we just happen to have leadership that helped us. But it really does take a village, a community, whatever it is, but we need help in these areas. And we need better mental health care. So sustainability, well, we certainly need marketing, and we don't have much of a marketing budget. That would really help. It's great to get TV ads. What we're told a lot of times is it has to be really special. Well, survivors, everyday survivors, are special to us, but they're not necessarily special to our media. I try to sell it. It's hard to get sold, so I commend you for that. We need billable models, and we need advanced practice nurses at the table because they're doing a large portion of this care, and really they're doing it very, very well with physicians. And so it's something that really matters to all of us, and it's a great model. And we need to look at downstream referrals. You know, we might be a lost leader, like mammograms and lung cancer screening, but if we're generating all these referrals and we're helping hospitals that are outside even the cancer arena in terms of care and testing, and it's a win-win for everybody because we're getting early intervention as well as early diagnosis. Care coordination, as I mentioned, is really difficult. And we hope that we can better generate communication and documentation with our primary care, as well as having, as I already mentioned about electronic health records, we need to get that to be a better place for all of us. Survivorship, well, we need embedded programs, but we also need satellite clinics. We need telemedicine to move quickly. It's really not moving quick enough state by state with all of the legislation things. Self-management for patients, we need to really develop more language nationally about self-management for patients. And lifetime clinic surveillance, it really is different in each community or each state. I realize there's more primary care in that in some areas, but in our area, we really are owning more of an oncology home for our patients. Thank you.